Thank you, Suhashini, for those kind words. Now, I'm coming into bed half an hour before lunch, and I'm supposed to, I think, finish quickly, but I have been given a bit of a difficult task to update you on the management of the management guidelines of bipolar affective disorder. So this is mainly aiming this at the trainees, and I hope to run through this a bit comprehensively. So I'm looking at four main guidelines: the 2014 NICE guidelines, the British Association of Psychopharmacology guidelines 2016, the CANMAT and ISBD 2018, the Canadian guideline, and the newest one, the RANSAP 2020. I'll be looking at how not only the differences in the guidelines, but also how these how guidelines and treatment have changed over the years. And also I'll be looking at it in different components: treatment of acute mania, acute depression, maintenance, and also mixed episodes. And I'll be going fast. If you have problems, we'll maybe take it in the question time. Of course, just for the benefit of the trainees, I can tell you, just to remind you that guidelines are merely guidelines. They're not the gospel truth. And real patients sometimes might need different treatment. But this is for academic purposes. And also, don't think that you need to remember all these guidelines for your exam. It's not necessary. You don't need to know what is first in NICE and what is first in BAP. But I think you might be expected to know the level of evidence for a particular medication in a condition, right? But this guideline, especially the BAP guideline and the new RANSAP, is very useful because it gives a lot of information on bipolar affective disorder, a lot of new papers. If you take acute mania, the NICE 2014 is very simple. If it's not a mood stabilizer, they ask you to start an antipsychotic. The four ones that came top on Cipriani's trial: olanzapine, haloperidol, risperidone, and quetiapine. And if not responsive, you can consider adding lithium or valproate. If he's already on a mood stabilizer, which they think is probably lithium or valproate, you optimize the mood stabilizer, and if not responding, add one of the four antipsychotics given before. Let's move on to BAP 2016. Again, they divided the same way. If you're not on long-term treatment, it's the same first-line drugs. BAP and NICE, there are differences, but sometimes this is same in mania. And of course, they give some alternatives, like valproate, aripiprazole. Valproate, they put it down because of the teratogenic risk, mainly in the females. Aripiprazole, lithium, other antipsychotics. Lithium, because it's slow to act, it's not going to be that fast. And of course, on long-term treatment, again, it's the same as NICE. You go for the highest tolerated dose of the current treatment: lithium, valproate, or one of the antipsychotics. If there's a poor response, you add the second medication: lithium plus antipsychotic or valproate plus antipsychotic. If it's refractory, they recommend clozapine or even ECT. CANMAT, they say they are looking at a more holistic picture when they're coming for they're looking not just at acute mania, they're looking at the treatment, preventing mania, preventing depression, preventing the long-term picture, as well as safety and tolerability and the risk of switch. And they have given monotherapy options as well as combination options. The clinician must decide whether we are going for a monotherapy or a combination. So CANMAT, the difference here is the monotherapy options, they're promoting lithium as number one, lithium, quetiapine, this is the hierarchical order, valproate, and they brought in some of the newer antipsychotics and taken down olanzapine and haloperidol. We'll come to that later. And of course, the combinations are lithium and valproate plus aripiprazole or risperidone. Acetaminophen we don't have. So they have taken olanzapine and haloperidol to the second line, which is the current trend, mainly due to the serious side effects and tolerability issues. And combinations with olanzapine are also considered second line, and the lithium valproate combination is also considered second line. Let's move to the RANSAP. The RANSAP 2020 is the newest one. They prefer monotherapy over combinations because of better compliance and fewer side effects. If it is severe mania with agitation and psychosis, they say go for a second-generation antipsychotics, especially with the sedative effect. Mild mania maybe can manage with only a mood stabilizer. And they talk of choices. The first choice is monotherapy. Again, antipsychotics, they are mainly on risperidone, quetiapine, and aripiprazole. Olanzapine and haloperidol downgraded again. Combination choices, lithium and valproate with the first line, lithium or valproate the first line, second generation. Mood stabilizers, lithium or valproate. And it's graphically given here. They are mainly first line choices after the ones we have, aripiprazole, risperidone, and quetiapine. And also they call combinations of a second generation antipsychotic with lithium or valproate. And alternatives are their second line. So as you see, haloperidol and olanzapine go on to the second line, and any combination with olanzapine is also now considered second line. This is in graphical form. So the monotherapies and the combinations, alternatives. ECT is also considered. So just look at ECT in mania. NICE is not doesn't encourage that much. But BAP says severe mania, treatment resistance mania, and mania in pregnancy. And they all go to say the 60% remission rate in manic patients who had previously responded poorly to lithium or antipsychotic. They use this term dopamine antagonists and partial agonists for antipsychotics. That's the term that BAP uses. So CanMat gives it as a second line option, and they say 80% of patients will show marked clinical improvement, and they promote bifrontal electrode placement, faster response, and fewer cognitive effects. And RANSAP 2020 again notes it as a useful option, and they continue to say that bifrontal ECT has a more rapid action. So the duration of treatment for mania, NICE says after 4 weeks, after 4 weeks of resolution of symptoms, to discuss with the patient about long-term treatment. If the patient prefers anti-manic, to continue for 3 to 6 months and review. BAP talks about complete revision in about 3 to 6 months. CanMat advises to continue the anti-manic treatment, either the second generation or the mood stabilizer, for 6 months. Now, let's go to a more controversial topic, bipolar depression. And I can remember as a trainee way back in 2005 and 6, Dr. Amerasinghe asking us to debate about bipolar depression and antidepressants. So it used to be controversial then, still controversial. Still, these rankings that I'm going to give are very unstable rankings. One clinical trial will change everything. So, and of course, nowadays, they are not only looking at clinical trials and meta-analysis. I think that I should have started at the beginning. Many of these modern guidelines are now taking into account large naturalistic studies that are done. And they say they also give very useful information, not just the meta-analysis. NICE, if you're not on any medication, they promote this fluoxetine olanzapine combination. That's what they're number one. And the other options they give are quetiapine, olanzapine, or lamotrigine. If the patient is on lithium or valproate, again, the advice is to optimize the mood stabilizer, and if there's no response, again, the number one is olanzapine fluoxetine combination, plus the 3 antipsychotics I told earlier. ECT is not recommended in NICE, and of course, they say to offer a psychological intervention developed specifically for bipolar disorder. This NICE recommendation has been heavily criticized in articles as well as in the BAP guidelines. BAP will go 2016. If you are not on long-term treatment, their first line would be a second-generation antipsychotic, mainly quetiapine, lurazidone, or even olanzapine. The best evidence, they say, is for quetiapine, 300 to 600 milligrams. Second option they have given is an antidepressant with a mood stabilizer or a second-generation antipsychotic cover. And there they give the fluoxetine olanzapine combination, which NICE recognizes so highly. And another top option is lamotrigine with a mood stabilizer. They give a place for ECT in severe or refractory depression, and they consider psychotherapy only as additional treatments. If somebody is on long-term treatment, first option, of course, is to optimize the mood stabilizer or the antipsychotic, if not to add as previously told. So, BAP, there are some interesting points about lithium. They say the evidence in lithium in acute depression is quite poor, but treatment guidelines have repeatedly recommended use of lithium as a first line in bipolar depression. They feel that it may be because of its anti-suicidal effects and prophylactic effects in the long term. They are quite dismissive of valproate, saying it's poor evidence with 4 small trials in acute depression, not prevention, right? If you go to CanMat, the Canadians, their first line option again is quetiapine, 300 to 600 milligrams, lithium, but mind you, they propose a lithium level of 0.8 to 1.2 milliequivalents per liter. And lurazidone with a mood stabilizer, lamotrigine 200 milligrams, lurazidone alone or lamotrigine plus mood stabilizer. Now lamotrigine, again there's a discussion about lamotrigine of some failed trials in lamotrigine. What CanMat and Ransap says is that lamotrigine trials have too short duration. By the time they come up to 200 milligrams, they have given only 2 weeks of 200 milligrams. So that is the reason for some of the failure of some of the trials in lamotrigine, because it's too short duration of the therapeutic dose. CanMat gives valproate as a second line option and also SSRI or bupropion. They are avoiding tricyclics and venlafaxine for obvious reasons, plus a mood stabilizer. So antidepressant plus mood stabilizer. The strong antidepressants, they are not recognizing because of the switch risk. ECT, and of course the DIVA, which is cariprazine, it's also given as a second line option. So when it comes to Ransap, they say to give mood stabilizers preference over the second generation antipsychotics. So there's a difference between the BAP and CanMat, where they give top priority to quetiapine and olanzapine, where Ransap says to consider lithium, lamotrigine, and valproate as the top choices. And the second generation antipsychotics, 2 are considered in first line. They are quetiapine, lurazidone, and cariprazine. So this is in graphic form. The mood stabilizers in order of priority: lithium, lamotrigine, and valproate. The second generation antipsychotics, again in the order of priority: quetiapine, lurazidone, and cariprazine. Ransap generally goes for in the alternatives. They have given a lot of alternatives and quite complicated. Mood stabilizer plus antidepressant combinations, mood stabilizer plus second generation antipsychotic combinations, and also they have given a place for ECT. Now, this question of switching, antidepressants and switching. BAP says to use antidepressant with a mood stabilizer or a second generation antipsychotic to reduce the risk of switch. And they say TCAs and venlafaxine have a very high risk of switching. Now, Ransap says that it should be case-based decision. If past manic episodes have been very severe, or if the consequences of the manic switch is very severe, not to use or to be very cautious about antidepressants. And they say in some patients the manic episodes have been mild manic episodes, and in that situation, antidepressant with combination, of course, with mood stabilizer can be used. Discontinuation of antidepressants. Here again, there is a bit of a discrepancy between BAP and NICE. NICE says 4 weeks after resolution of symptoms to discontinue the antidepressant, discuss about long-term treatment. Whereas BAP says to follow the unipolar guidelines, unipolar depression guidelines, which is of course 6 months. And then of course both agree to taper off for 4 weeks. And now we move on to a bit more complicated thing, the mixed episodes. Now, BAP would differentiate the mixed episodes. NICE doesn't talk much about the mixed episodes. BAP says the acute mixed episodes with predominant manic symptoms, we go with a atypical and second generation antipsychotic. They are from the ones we have, olanzapine, risperidone, aripiprazole are ones they are recommended. If there is a depressive episode with mixed features, they are not clear. They say the evidence is not very clear when there is a depressive episode with mixed features. But they are very clear that there is no indication to either start or continue treatment with antidepressant in a mixed state. CanMat again agrees mainly with the same thing, the second generation antipsychotics, olanzapine and aripiprazole, and valproate in a mixed state. Ransap, they note that it's very challenging to treat. Suicide rates are higher in mixed states. And they propose to use medications that are anti-manic, antidepressant, and mood stabilizing. And unlike BAP and CanMat, they prefer lithium and valproate. And to some extent, quetiapine, which is anti-manic, anti-depressive as well as mood stabilizing. And they reiterate, do not use antidepressants. And olanzapine is given as an alternative, as well as there's a place for ECT. It's given in a graphic form. Lithium, valproate, and quetiapine in the bipolar mixed. If it is mainly mania, predominant mania, to go with aripiprazole. And if it is predominantly depression, to go with lurasidone. And of course, they have given some alternatives. Olanzapine is always put to the second line, mainly because of its metabolic side effects. So any combination with olanzapine, either depression or mania, mixed episodes you can give. Carbamazepine is given as an alternative in bipolar. Right, so I think I can make it 14 minutes to go. So maintenance treatment. I don't want to delay your lunch. So, so NICE 2014, lithium is a drug of choice. So lithium is an effective, add valproate. If lithium is poorly tolerated, consider valproate, olanzapine, and quetiapine if it was effective in the last episode. Some of the trials have been like that. If your last manic episode was treated with quetiapine, continue quetiapine. If your last depressive episode was treated with quetiapine, continue quetiapine. Let's move to PAP. Lithium is the first choice, best overall evidence. And they say out of the ones, good evidence to prevent manic relapse is lithium, olanzapine, quetiapine, risperidone long-acting, and valproate. Preventing depressive relapses, lithium, quetiapine, and lamotrigine. So you can see it's only lithium and quetiapine that have good evidence for preventing both manic and depressive. So lithium, BAP says this talk of lithium being lithium monotherapy being gold standard, they don't agree with that. They talk about more combinations in bipolar. And combinations prefer to monotherapy. And if manic polarity, they talk about lithium plus antipsychotic or valproate, 2 antimanic agents if the predominant manic polarity. If it is a depressive polarity, again, 2 antidepressive agents, lithium, lamotrigine, quetiapine are the preferred ones. Olanzapine also comes into the picture there. So BAP prefers the combinations. Clozapine, if it is effective for refractory mania, can be continued. ECT, maintenance ECT has a place when medications are not effective. And of course, they talk about adjunctive psychotherapy for subthreshold symptoms. CanMat 2018. Now, there's an interesting point which I want to highlight here in CanMat guidelines. They talk about an increasing evidence to suggest that for a subgroup of patients, bipolar affective disorder may be a neuroprogressive illness in which recurrences are associated with reductions in brain gray matter and white matter volumes, worsening cognitive impairment, decrease in inter-episodic recovery and functioning, a higher rate of and severity of relapse, and a reduced rate of treatment. So this is not what we were taught when bipolar had good functional inter-episode functioning. We know clinically that not all bipolar patients are having good inter-episode functioning, and that's what they're talking of, a minority of bipolar patients. So they talk of first-line monotherapy or first-line combinations. Once again, CanMat considers lithium as the gold standard. So again, it's up to the clinician to decide whether to go for monotherapy or combination. If it is monotherapy, lithium, quetiapine, valproate, and they have brought in lamotrigine and aripiprazole as maintenance agents first line, which is not in keeping with the BAP, because lamotrigine, as you know, is mostly effective against depressive relapse, and aripiprazole probably against manic relapse. So, but they are brought in as monotherapy. And combinations is mainly quetiapine with lithium or valproate, or again they have aripiprazole with lithium or valproate. So maybe that's what they are saying. They are looking at not just the they're looking at more all the aspects. But they don't, unlike BAP gives evidence for everything, CanMat doesn't give really explanations why they put this here, right? Whereas BAP would give it. So maintenance in CanMat, second, as I said, olanzapine again down to second. And also they have brought risperidone long-acting injection, which is the one that we thought had the evidence. They brought it down to the second line. Aripiprazole long-acting is the first line. And paliperidone is effective more than 6 milligrams. And the combinations are there. Right. Now the Australian guideline, the new one, takes a more holistic approach, and they say maintenance, the emphasis is on appraisal of the illness course and formulating a preventive strategy. So they say to study the illness course, predominant polarity of the illness, the pattern of the illness, is it, and the prior responsiveness and the current precipitant. So this is in graphic form, the pattern of the illness, whether it's punctuated or perpetual, predominance, and the prior response and the precipitant, before you come to decision about your maintenance preventive strategy. So once again, if you read the RANSAP, you realize that they prefer monotherapy, mainly of the less side effects, and mood stabilizers are preferred to antipsychotics. So their first line is again lithium. So you can see even after so many years, lithium remains number one in most of the guidelines for maintenance. Quetiapine and valproate. And here they little different. Aripiprazole long-acting if there is a manic polarity. Not aripiprazole long-acting if there is a manic polarity. And lamotrigine only if there is a depressive polarity as monotherapy. Of course, the combinations are there, lithium with quetiapine, valproate with quetiapine, and lithium with valproate. Lithium with aripiprazole. So it's in graphic form. So you can see if it is monotherapy, if it is manic polarity, aripiprazole, lamotrigine if it is depressive polarity, if it is both, otherwise if you go with lithium, quetiapine, valproate. Combinations are aripiprazole, lithium and quetiapine and valproate. If there's a manic polarity, you might add aripiprazole. Alternatives, they have given alternatives. Again, always olanzapine comes second line nowadays. So that's a mood stabilizer. Carbamazepine and olanzapine are monotherapies. If there's a manic polarity, risperidone comes in. And of course, there are so many other combinations that you can go with. Some of these guidelines recommend that you exhaust all the first line combinations before you go to second line. So, I mean, if you try to do it practically, you'll be treating the patient for years and years before you try ECT, right? So don't take this literally. I mean, these are, you need to take it practically. So I just thought, talking a little bit of rapid cycling, BAP says, when we were trainees, we were told that valproate was better for rapid cycling, I can remember, but there's nothing like that in these guidelines. They say to identify and treat hypothyroidism, substance use, consider tapering and discontinuing antidepressants, and there's no specific treatments for rapid cycling. That's what BAP says. CanMat says the same thing, but they add that rapid cycling may need combination of mood stabilizers. Long-term antidepressants. Now, is it, BAP says, and don't use antidepressants as monotherapy, but long-term antidepressants are effective in a minority of patients. And BAP says that some guidelines have gone too far in prescribing antidepressants long-term. Whereas in individual patients, if the patient, once you stop the antidepressant, if the patient continues to relapse to depression, there is a place for long-term antidepressant therapy. And they are asked to use the clinical judgment. Right. And finally, discontinuation of long-term treatment. Just want to point out what BAP says. Following discontinuation of medicine, the risk of relapse remains, even after years of sustained remission. So they really don't recommend discontinuation even after many years of sustained remission. If you do discontinue, that does not mean you discontinue engagement with the patient. You need to continue to engage with the patient and monitor the patient for relapse. Okay, so I've done in 25 minutes. So we have 5 minutes for questions. Okay, I hope I didn't confuse you.